Hi everyone, my name is Alicia and I'm one of the MUPPITS members this year, part of the academics team. So I'm going to be walking you guys through the musculoskeletal / neurology lecture series for this year's revision. Hopefully you guys find it helpful. So how I'm gonna structure it for musculoskeletal, obviously got these matrix conditions, neurology, these matrix conditions. We'll go through a couple of past exam questions and then we'll go through each conditions. Also do a quick summary at the end with just matching like buzzwords / phrases to the correct condition. And hopefully you guys find it helpful that way. All the slides will be available as well on the MUPPITS Google Drive. Let's get started. So in the following clinical scenario, which of the condition listed below is the most likely diagnosis? A 3-year-old boy comes in with a history of 3 days high fever and refusal to walk. He looks unwell and has a temperature of 38.5 degrees. Examination of his right leg is difficult and he is reluctant to be examined. What do you think is going on? So this one's septic arthritis, so option G. Key things pointing to septic arthritis is that this 3-year-old boy has a high fever, 38.5 degrees, and he looks unwell. So those two things to me are like, okay, septic arthritis. Just having a look at the other options that other people may have done. Transient synovitis, the child's too unwell. In transient synovitis, they appear generally well. They just have like a limp post-viral illness. Don't think the other ones are, I don't think there are many distractors, so hopefully that was okay. But regardless, we're going to go through the conditions shortly. Next question. A 16-month-old boy presents with reluctance to weight bear on his right leg and had a low-grade fever. He's been unwell and miserable for the previous week. His localized tenderness over his right distal femur. Plain radiographs were normal, as was his white cell count, but inflammatory markers were elevated. What do you think is going on? So the answer to this one is osteomyelitis. So just move my camera. So option S, osteomyelitis. Good job if you guys got that one. For this one, these do present septic arthritis and osteomyelitis. They do present similarly, but for this question, his white cell count is normal and he's not like systemically unwell. Yes, it says he's been unwell and miserable, but he's got a low-grade fever. And someone with septic arthritis is going to have a high-grade fever, going to be systemically unwell, as opposed to osteomyelitis. They're going to be a bit unwell with a low-grade fever. And that's the main differentiator for me when I tackled these questions last year. So let's go through them. Firstly, septic arthritis, obviously inflammation of inner joint resulting from an active infection. Obviously, usually Staph aureus from the skin, followed by strep. What does it look like? Get an acute onset presentation. You get the limp, the non-weight bearing child, pain on movement or at rest. And importantly, they can be systemically unwell, i.e. febrile. In most of the practice questions you see, they'll paint them as systemically unwell to help it be a bit easier for you guys to differentiate. And also importantly is differentiate on examination. You get an erythematous red swollen joint here that you don't get in osteomyelitis, or in osteomyelitis, if it's red and swollen, it's a very late sign. So key things for septic arthritis: systemically unwell, erythematous, warm, red, hot, swollen joint. investigations and management. Main things that are unique for this thing is blood cultures and synovial fluid joint aspirate. And in terms of management, IV antibiotics and urgent ortho referral are the main things you want to think about. This is just a hip X-ray showing septic arthritis. So next condition, osteomyelitis, the last R1 for musculoskeletal conditions. This one's an infection of the bone and or bone marrow. Thus, it usually affects the metaphysis of the bones. And 2/3 cases are lower limbs. How this condition presents, you get your limp, non-weight bearing child, localized pain and tenderness, doesn't really help you too much when you're trying to do an exam. Things that will help you differentiate this one is usually not systemically unwell. So yes, they could have a low-grade fever. Yes, they could describe the child as miserable, but they're usually not like systemically unwell with a higher grade fever and deranged like vitals. On examination, pain on movement, localized tenderness, like I said before, soft tissue like erythema and swelling is usually a late sign in osteomyelitis. So often they will not have erythematous skin or like a swollen joint because it's a late sign. Investigations, quite similar to septic arthritis. Main things you're thinking about are blood cultures, imaging. MRI is most useful for if they've had symptoms for less than 2 weeks, but for symptoms greater than 2 weeks, X-ray becomes useful because that's when you can start to see destruction of the bone. Management, similar to septic arthritis, analgesia, of course, IV antibiotics, and also referral. So next set of questions. A 2-year-old girl has an 8-week history of a painful left knee that was stiff in the morning and has become progressively more swollen. Examination revealed a left knee effusion associated with a mild flexion deformity and quadriceps wasting. What do we think it is? Lots of choices to choose from. Obviously, I think your exams are now A to E, which will be a lot easier. So great job for anyone that got K. K is juvenile idiopathic arthritis. Key things in this stem that points us towards that chronic history. It's 8 weeks. Obviously, they're 2 years old. Stiff in the morning. That to me, and like this progressively more swollen. Those 3 things are really pointing towards the juvenile idiopathic arthritis. All right, let's go through this. So, juvenile idiopathitis is an umbrella term and encompasses a range of chronic pediatric arthropathies that have objective arthritis before the age of 16. And they're just listed here. I know it's a blurry table, but it's like a really good table, I thought. So, there's oligoarticular, polyarticular, systemic, psoriatic, and early rheumatoid arthritis. All of these come under the umbrella term of juvenile idiopathic arthritis. I think out of this table, it's probably important to note that like oligoarticular is by far the most common, and also when you think about what's present in terms of in bloods, if Anna's present, it's actually usually present in oligoarticular, polyarticular, or psoriatic. So how do people present with this condition? Reduced mobility, the main thing is it's going to help us think about this in a MCQ setting is morning stiffness and any extra articulate changes like a rash or nail changes. On examination, they're also a well-looking child. That's another key thing to think of, to like note for this condition. Investigations, nothing too exciting. Bloods, although you get taught a lot about like ESR and rheumatoid factor, actually not overly useful, but in OSCE setting, absolutely build them off if you remember. Imaging, you can just do plain X-ray. Management, I think, is a good one to remember for this condition. Came up a little bit. So with pharmacological management, you start off with simple analgesia, NSAID, glucocorticoid joint injection. Then you step up to methotrexate. If the patient is still not responding to methotrexate, then you can introduce biological DMARD. So next question, in the following clinical scenario, which condition listed below is most likely diagnosis? Got a 13-year-old boy presenting with mildly painful limp and was noted 3 days earlier. He's afebrile and systemically well. He is overweight. Examination reveals the limitation of internal rotation, flexion, and extension of his left hip. So a few buzzwords here. So great job to anyone did H, which is Sufi. Big buzzwords is like 13-year-old boy, they're growing, and he's overweight, as well as like you get this limited range of motion in these particular movements. So even like if for a stem cell, they're overweight, systemically well, growing pain, like growing boy, those things are really pointing towards a Sufi. So the next range of conditions we're talking about now come under the orthopedic disorders in childhood. It covers a range of different conditions, and I'm just going to be talking about a few of them. So for SUFI, what actually is it? It's a posterior and inferior femoral head displacement. Risk factors, like I said before, the big buzzwords, they're going to be male, obese, and adolescent or a teenager. They're going to be growing, going through a growth spurt. In terms of investigations, CT X-ray management, urgent surgical referral, get some complications as well. I think that's the main thing about just like being able to identify it on presentation though. Next one's Perthes disease. What is it? It's idiopathic avascular necrosis of the femoral head. Risk factors male, 4 to 8 year old age bracket. Buzzwords for this one is you're getting, they present with like an antalgic gait, and then also they'll say on a hip X-ray you get flattening of the femoral head. Management is conservative and surgical, so 2 arms there. But yeah, main thing, get this flattening here, as you can see of the femoral head, and they'll often say they present with an antalgic gait. So transient synovitis is the next condition. It's also known as irritable hip, and basically it is what, as the title describes it, it's an inflammatory process where you get inflammation affecting the joint synovium. Risk factors, they're going to have a preceding viral illness, and they get a full recovery in approximately 2 weeks. So biggest thing to differentiate this condition, preceding viral illness, might not say that a virus, might say that, an ERDI or a cold, and they're often a 3 to 10-year-old age group. Management, rest, supportive therapy, analgesia, NSAIDs. Next one, osgood-Schlatter disease or osteochondritis of the tibial tuberosity. So this one's strain on the patellar tendon where it inserts on the tibial tuberosity here. Patellar tendon, tuberosity. So you get like inflammation around here. Risk factors, how you're going to differentiate this condition in an exam setting will be a young athlete or the child's having a growth spurt again, and they're going to have this knee pain, or like a tender swelling over that tibial tuberosity. Investigations, clinical diagnosis, management is really just simple analgesia, supportive, you can refer to physio. But I think the main thing to remember is they can continue normal physical activity just within the child's level of comfort, obviously. Next one is DDH or developmental dysplasia of the hip. This one comes up quite a bit. What is it? It's a disorder where like neonate has either already dislocated their hip or they're more prone to dislocating the hip. And there's two main reasons why. It's either the socket, so this part of the hip joint, so the socket portion of the hip acetabulum is like more shallow, so it's more prone to dislocating, or they may have slack ligaments. In terms of risk factors, this comes up quite a bit, mainly in the clinical setting, like placement. So you think about the 4 Fs, very pretty easy to remember: female, frank beach, family history, or foot deformities. Foot deformities really refers to intrauterine packaging deformities. So foot deformities as well as torticollis, plagioccephaly. Presentation identified through screening of neonates mostly, and it's important to the Barlow sign and the Ortolani sign. I'll talk about that in the next slide. Investigations, ultrasound for monitoring progress, management, splinting, bracing, and surgical reduction in severe cases. So here we go on the left, we've got the Ortolani sign and Barlow's test on the right. They're done in conjunction with each other, as hopefully you've seen on placement. So you start with a Ortolani test, and then a positive sign is when you get that you can actually reduce the femoral head into the acetabulum. So here you get you often hear like a clunk, so yeah, an audible clunk as the hip reduces. Then after you do that, you open up the legs by adducting them. And a positive test is when you can actually palpably, like the head of the femoral head slips out of the acetabulum. So they're used in conjunction, like I said, start with the Ortolani test and then do the Barlow's test. That pretty much concludes the musculoskeletal portion of the talk. I think, orthopedic disorders in childhood, there's so many, and we haven't gone over all of them, but we've gone over the main ones. And I think it is important to just be aware of there are quite a number of more. There is a bit of crossover with like the heme-onc matrix. So I've just put a couple here as well, just to think about, like fibromyalgia, osteosarcoma, and ALL. Probably good ones to revise on your heme-onc matrix because, there's crossover with the musculoskeletal. So hopefully you guys can revise that with whoever's taking those matrix revision lectures. But yeah, just quickly, fibromyalgia, want to think about it with someone who's female, got widespread tenderness and, weight loss significant weight loss over a year, fatigued. We consider fibromyalgia, osteosarcoma, a non-tender swelling that doesn't go away. You get this sunburst appearance on X-ray. And then ALL, like up to as much as 40% present with just bone pain and arthralgia. So I'm going to definitely rule that out if you have a child presenting with that. Alrighty, so just as a quick summary revision, we'll go through buzzword phrases and try to guess the condition. I think this is a really good way to revise PEDS for a Monash exam because it is very buzzword heavy. So I definitely encourage you to do this. MUPPITS also has a PowerPoint where for each matrix topic there is a set of tables like this. So if you want to revise using that, I would definitely recommend that. And that's available on our MUPPITS Drive. So you can check that out. But we'll go through this one, so the musculoskeletal revision table. So young teenage girl, knee painful lump on shin. What do we think it is? Osgood-Schlatter disease. Next, young teenage female, knee pain, especially standing from sitting or walking upstairs. What do we think this one is? So this one's one we haven't gone over. Never came up on the exams last year, but has came up like probably one or two previously. So that's why they've got that here. I wouldn't go putting that on on my notes just would know it from like these buzzwords. And then hopefully, and then you'll be able to, like, if it does come up on the serious exam, you can rule out all the other ones first. But yeah, chondromalacia patellae. Next one, bilateral painful ankle swelling, buttock rash. Again, haven't gone over it today, but hopefully with buttock rash, you know which one it is. So it's HSP, hip and knee pain, and that's also in like your heme, I'm pretty sure. It's on one of the matrix conditions of PEDS, so as I said before, there is a lot of overlap. So next, hip and knee pain, early last week, afebrile. What do we think it is? Hopefully we know this one. Transient synovitis. Next one, this one is another revision one. Indigenous child knee pain and swelling, febrile, murmur at apex. What do we think it is? Rheumatic fever, yes. Next one, flattened femoral head, less than 12 years, child's limping. Okay, guys, flattened femoral head. We should know this one hopefully by now. Perthes disease. If you still feel like you don't know it, that's so fine. Like you'll get it after a few weeks of revising these buzzwords. They just stick. So next one is Gower sign, positive, dilated cardiomyopathy, enlarged calves. We'll cover this in neurology. So I'll go over, just briefly past this phrase because we're going to discuss it in neurology. It's Duchenne's muscular dystrophy. So next thing, tongue fasciculations, absent deep tendon reflexes, severe hypotonia. Again, we're going to discuss this one in neurology. It's spinal muscular atrophy. Child wakes up from sleep with no cause, pain in shins or feet, age 3 to 12. This one's a bit of a funny one, but hopefully, yeah, it's growing pains. But yeah, if that's all they have, and they'll probably pull on the stem, give you a bit more detail, but always good to consider growing pains as an actual answer. Next one, bow legs, bead-like costochondral junctions and craniotabs. It's another unique one. So rickets, fall from monkey bars, bruises on back, spiral fracture. So this is no accidental injury, does come up on exam. So do remember that as a differential, particularly, it's like they're not matching like a spiral fracture and a fall from monkey bars. Like someone's fall from the monkey bars, it's unlikely going to have a spiral fracture. And then overweight teenager, limp, painful hip, external rotation of leg. So hopefully you guys know this one. So we got Sufi. Lastly, hip pain, fever, irritable and miserable, pain on movement, septic arthritis, because they are, they're irritable, they've got a fever, they're systemically unwell, septic arthritis. And I just got this one here. Hopefully it'll help with anyone with OSCE practice. Definitely go over a child presenting with a limp, very osciable, and a good way to think about like differentials is like or screen for different conditions is like by dividing it like this. You got malignancy, infection, mechanical stuff, and then your inflammatory conditions. Alrighty, guys. So that is MSK done. Go through like a similar format for our neurology conditions. For our ones, we've got febrile convulsions, epilepsy, cerebral palsy, and there is quite a lot of other seizure conditions that do come up on FAQs that kind of fall within these. And our two, status epilepticus, migraine, arthritis, Duchenne muscular dystrophy, spinal muscular atrophy, and Guillain-Barre syndrome. Right, guys, let's go. So, question to start off with, in the following clinical scenario, which of the below is most appropriate? Got a 7-month-old boy presenting with 1 week history of sudden drawing up of his legs, flinging out of his arms, and hunching of his shoulders and neck. These episodes have been noted to occur many times, most days, for several minutes. What do you think it is? So this is J, so infantile spasms. big buzzwords is the sudden drawing up of his legs and flinging out of their arms, and they're 7-month-old. Yeah, many and occurring many times, really big buzzwords. So yeah, we'll go through these R ones now, starting off with febrile convulsions. So what is it? They have a seizure in a febrile child, 38 degrees, but importantly, it's without prior neurological abnormality and without signs of central nervous system infection. Most are benign, they're associated with simple viral infections and present in how they present to differentiate in terms of the different categories of febrile convulsions. So you can have a simple febrile seizure, a complex febrile seizure, and afebrile. An afebrile, written afebrile febrile seizure, but it's like afebrile seizure. So starting off with simple, all of the following: generalized tonic-clonic, duration less than 15 minutes, and complete recovery within an hour. Last two dot points really help being able to pick that one. Complex, you get focal features at onset of the seizure. Duration is greater than 15 minutes, and you get incomplete recovery within an hour. And for complex, you get recurrence within the same febrile illness that you don't get with simple. With the afebrile seizure, obviously, it makes sense that it's seizures in an acute infectious illness without documented fever. Investigations can break it up into simple or complex febrile seizure. For simple, there's no investigations needed unless there are any like red flag symptoms and you need to rule out other pathologies. For complex febrile seizures, so you have to consider the source of the seizure, source of the source of the fever. And yeah, based on that, then you can do particular investigations like a lumbar puncture, or yeah, obviously bloods. More likely to consider central nervous system imaging and complex febrile seizure as well. Management, supportive therapy, just managing the fever with Panadol and Nurofen. So the next one is epilepsy, defining epilepsy to 2 unprovoked seizures greater than 24 hours apart. How they present, as I'm sure you guys did in year 3, it's important to think about before, during, and after. So before, is there any precipitating factors like triggers, like a sleep deprivation, or was there any drugs, alcohol, flashing lights? Do they have a preceding aura? During, important to think about tongue biting, urinary incontinence, things like that. Then after is the level of consciousness. Are they confused for a prolonged period after? Epilepsy investigations, you can do an EEG, but in the acute setting, it's not going to actually help you that much. And neuroimaging, management in the acute setting. So don't restrain them. You're following your ABCDE approach. If needed, you can provide supplemental oxygen with a non-rebreather and remove any dangerous objects. Most cease within 5 minutes. In the long term, this is where you're thinking about lifestyle. You can keep like a diary to try and identify triggers and avoiding them with education. And it's really important to educate them on safety. So if a safe child has epilepsy, you have to really have a serious discussion about swimming and things like climbing. So pharmacological, sorry about the typo error. Usually start them after 2, so 2+ unprovoked seizures occur. And pharmacologically, these are different medications. You don't have to remember all of them, but they come up quite a lot. So like absence seizures, ethosuximide, it's a big one that comes up. And obviously like the big ones are carbamazepine, the lamotrigine, these ones, levetiracetam, they come up quite a bit. Phenytoin, sodium valproate. Yeah, a lot of them do come up, but Absent seizures, this one's unique if they succinate. Yeah, so don't remember the whole list, but it does help to be familiar. So next conditions are R2, status epilepticus. What is it? It's a continuous seizure of greater than 5 minutes or 2 seizures without full recovery in between. So I've just asterisked that because that is the definition, and it's a practical definition written here. But it is good to be aware, like the formal definition of status epilepticus is actually different to that. And it's written as, tonic seizure lasting for 30 minutes or longer, or recurrent seizures without regaining consciousness in between and lasting greater than 30 minutes. It's actually the formal definition, but for exam's sake and everything this sake, we're using the operational definition. So how they present, obviously, you're getting the seizure, and yes, pretty much the definition how they present. For management, the management is where the money is for status epilepticus. Obviously, you need to know the definition, but then the management is the next big thing. If it, sometimes with a seizure, supportive doctors ABCD for the first 5 minutes. If they have status epilepticus, it's going for greater than 5 minutes. This is where you have to think about pharmacological management. You have to obviously rule out any other causative pathology as well. So I'll go through that now. This is a status epilepticus management. I made like a quick summary here, but it's really good this flow diagram is really good to learn from. It's from obviously the RCH guidelines, but you're reassessing everything like after every 5 minutes. So first of all, duration of seizures greater than 5 minutes or it's unknown. We've got suspected causative pathology. If we're saying yes, then we're commencing active treatment. You're doing your ABCD, continuous monitoring oxygen, getting venous access, getting a BGL, those types of things, and you're giving the first benzodiazepine, sorry. So step 1, benzo. Then you wait 5 minutes. If they're still seizing, you repeat the benzo dose. Wait 5 minutes. If they're still seizing, then you give a second line agent. So that is phenytoin or levetiracetam. Then you wait 5 minutes. If they're still having an ongoing seizure, you give an alternative agent. So if you gave phenytoin in 3, you can give levetiracetam, step 4. If they're still seizing after another 5 minutes, then you're getting senior help, I see anesthetics hopefully there for like airway management already. But yeah, this is a very important flow diagram to remember, and again, very osteopable. So now the long and wonderful list of other seizure presentations to be aware of that we're going to go through now. It's just important to know, I guess, the buzzwords of these so you can pick them up on an MCQ presentation. But you wouldn't need to know these things in depth, like in an OSCE setting or anything like that. So the first one is Rolandic epilepsy, aka benign focal epilepsy of childhood. Age bracket 7 to 10. I've just put a little stem here about how they present, but the big buzzwords is like it occurs at nighttime or it's upon waking, and then they get a focal seizures. So like just facial symptoms, or they get this tongue movements or like a drooling. On EEG, buzzwords centrotemporal spikes and normal MRI. They're your buzzwords for your Rolandic epilepsy. Next one is childhood absence seizures. Getting a bit tired. It's a type of generalized epilepsy. So buzzwords for this, you get these staring spells. So like kids that have this, teacher might notice that one of the kids is just like staring in class for like periods of time, brief periods of time. It's often like how it's picked up. So other things to get sudden onset, sudden offset, and on EEG you get generalized 3HC spike and wave discharges. Next one, infantile West syndrome. So this one's early onset, 3 to 12 months, peaks at 5 months. 2/3 of cases are preceded by a developmental delay. And I should have written here, infantile West syndrome is also known as like infantile spasm. So you get that drawing up your legs, your neck flexion, you're flinging out your arms, child appears frightened. And yeah, they're the main things. And it's a poor prognosis, mainly with the developmental delay. Next one, breath holding. So this one's like a type of infantile syncope, and most common age group is 2 to 4. It's involuntary, obviously. And the buzzwords for this one is like they have a preceding noxious stimuli, and they cry, like perhaps they're crying a lot, and they lose consciousness, and they can go purple and get a posture color changes, as well as they can also get tonic stiffening / tonic clonic jerking. So that your breath holding ones away. I remembered it last year. It's come back to me as like, they're crying so much that then they're like, if you think about you crying so much, you can't catch your breath or you lose your breath, and then that's when they appear purple and have this seizure occur. That's just one way to remember it. All right, we're going well, we're nearly there. Next one's less common, but still important to just they exist. Reflex anoxic seizure. It seems like a fright or a scare. There's a clear trigger, like a head knock. They go pale as well, might hold their breath. And this one's got rhythmic jerking as opposed to the breath holding seizure. Next one, tic disorder. So you probably already know this one's sudden involuntary, repetitive, rapid movements. Number one primary movement disorder in childhood. If you have a vocal and motor tic, it's Tourette syndrome. Pseudoseizure, this one does come up in MCQs. It's often an older primary school age child or adolescent. And this classic scenario is like they lift their arm up in class. And then they consciously don't let it drop. And that's like a pseudoseizure. Lastly, Lennox-Gastaut syndrome. It's rare but really severe type of seizure, and it's characterized by multiple concurrent seizure types. So kind of like your complicated one. And then on EEG, you get this flow spark wave. I think this is the last page for the seizure ones. Juvenile myoclonic epilepsy. This one develops in adolescence. And yeah, this one really typically happens 1 to 2 hours of waking up in the morning or after a nap. Big buzzwords. The child's often sleep deprived, and they describe it as like a shock-like and irregular movement of both arms. It can also just happen in the fingers as well. For Dravet syndrome, this one does come up as well. It's a severe myoclonic epilepsy of infancy, autosomal dominant condition. Just got a small picture here talking about the symptoms more, but big giveaways are like it's drug resistant. It doesn't respond well to pharmacological medication, and then they can also get growth delays. Lastly, temporal lobe epilepsy. This one's always like associated with like a strong emotion or like a strong smell sense, like an aura like that. That'll be a temporal lobe epilepsy. All right, moving on to the next R1. This is cerebral palsy. This one actually doesn't come up that much, but it is R1, so it's important to revise. Hopefully, this is year it does come up a bit more. But it's developmental disorder of movement and posture. And there are different types of cerebral palsy. You can think about the motor types, where 70% is spasticity, but there's also dyskinetic, dystonia, and ataxia types. But then you can also affect non-motor pathways, leading to a seizure disorder, impaired cognition, like impairment in communication or behavior. How do these children present? You have to think about risk factors first of all. Often, they're a premature baby that had a torch infection during pregnancy or preeclampsia, mum, substance user. Otherwise, like other key things that associated with cerebral palsy is like the hypoxemia encephalopathy or like a neonatal stroke. So in history, big buzzwords, delay in the developmental milestone, again, asymmetric or uncoordinated motor patterns, early hand preferencing, and one-sided rolling. They are big buzzwords, as well as scissor gait and tiptoe walk. Just pop this here too. Doesn't come up, but if you are interested, I think it's good, really good to know, because this is a really common condition in life. There's different categories of grading cerebral palsy from 1 to 5, where 1 is like the least severe, where you can walk without limitations, and it goes to 5, which is where they're completely reliable on a manual wheelchair. So investigations, in an ENA, you'll be leaning towards using ultrasound, otherwise MRI. It's abnormal in 80% of the cases. You get periventricular, things like that come up include periventricular accumulation or congenital malformation. Management, I think it's good to consider. Could be osteoblitz and R1. So it's really 5 prongs. First, early detection. The younger you are, the more neuroplastic your brain is. So early detection is really important. The next one is managing the spasticity, such as dystonia. So to manage this, you can use muscle relaxants with oral medication, botulinum injection, splinting, to prevent any contractures. Then thirdly, physical therapy with a physio, to maximize strength and physical function. Fourthly, orthopedic procedures. This is a plus minus to correct any torsional deformities or contractures. And finally, is monitoring. So it's really important that you monitor them with like a hip X-ray, ultrasound for any hip dysplasia or subluxation as the child grows up. So next neurology condition is migraine. So this one's pretty straightforward. You guys would have done migraine in your adult medicine last year. Pretty much like the exact same. So hopefully it shouldn't be too difficult for most of you guys, but obviously severe type of headache, how they present, probably came across like the pound symptoms, that being pulsatile, like a 1 day duration, a unilateral, we get nausea and vomiting and disabling intensities. That's your photophobia, phonophobia. In a child, other ones you can get are like abdo pain and loss of appetite. And how it presents differently to adults, although it's more likely to be unilateral. And when we think about child compared to adult, a child is more likely to be bilateral compared to an adult. But yeah, within the pediatric setting, they're still more likely to have a unilateral headache. Investigation's not needed only if there's any red flags present. So management, I think important to go over the management. So acute, how I'd like to think about it is that you have to think about in an acute setting what you're going to do, then in like a long-term setting what you're going to do. So acute setting, you're limiting the stimuli, you're going in a dark room, dark, quiet room. First of all, starting with simple analgesia, NSAIDs. Avoid opioids is important. And then if they have ongoing pain and they're greater than 10 years old, then you can consider a triptan. They present you in an ED setting, you can consider starting on Dansetron if, they're vomiting, as well as if they're greater than 8 years old, you can consider clopramazine. So that's your acute setting. Long-term setting, lifestyle, you want to do like a headache diary so that they can identify triggers, and then through education, you want to try to avoid those triggers. And then as well, prophylaxis. Prophylaxis is indicated if patient needs approximately 2 to 4, like the migraine occurs approximately 2 to 4 times a month, and they need the treatment 2 to 4 times a month, being the triptans. But prophylaxis is propranolol if they are eligible. All right, so we're nearly there, everyone. Great job for hanging in there. Really, you guys find it helpful. The next two questions. So you got a 3-month-old breastfed infant is seen because of poor feeding and slow weight gain. On examination, he's noted to be floppy with poor muscle bulk and absent tendon reflexes. Absent tendon reflexes is huge buzzwords. And then also seen to have fasciculations of his tongue muscles, another huge buzzword. What do you reckon is going on? So it's on spinal muscular atrophy. So J, as I said, fasciculations of tongue, poor feeding, slow weight gain, in conjunction with like absent deep tendon reflexes buzzwords. Next one, 3-year-old boy, difficulty climbing stairs, generally unsteady on his feet, didn't like delay developmental milestone, didn't walk until they were 22 months, and on examination has enlarged calf muscles. So huge buzzword with the enlarged calf muscles, it's a Duchenne muscular dystrophy. So we'll quickly go through these last few conditions and then we'll wrap it up. So Duchenne muscular dystrophy, what is it? It's a progressive muscular disorder caused by the absence of dystrophin. Risk factors, boys only get it. It's like linked recessive. How they present, they get this waddling gait, calf pseudohypertrophy, and positive Gower sign. And this is the Gower sign here, where they from like crawling to like standing, they use their arms like to help them get up. They have to use the arms all along the legs. So they start with the lower limbs and they use their arms going up to their thighs to help them stand up. And that's the positive Gower sign. Investigations, don't worry too much. CK elevated, that's quite interesting, but that's the main one. That yeah, like blood CK elevated, that doesn't diagnose it, but something that's interesting, confirmed by genetic testing, and if that's not determinate, you can do a muscle biopsy. Management is supportive, and yeah, it's important to know that your life expectancy for something like this is 30 to 40 years of age, so it's quite a sad diagnosis. Also, buzzwords is like dilated cardiomyopathy as well. Next one, spinal muscular atrophy. So this one's degeneration of the anterior horn cells. That's where the motor neurons are. And that leads to progressive muscle weakness and atrophy. So it's an autosomal recessive inheritance of defect in the gene SMN1. For some reason that does come up, the SMN1 gene, so good to know. How would they present? Again, you get this progressive proximal muscular weakness and atrophy, but it's unique. You get this like frog leg position, alert face, absent deep tendon reflexes. Management, physio, OT, having trouble feeding, may have to insert NGT obviously, and there's also like emerging novel therapies for this one, which is pretty interesting, but wouldn't need to know for this year's exam. Lastly, Guillain-Barre syndrome. So you would have come across this one last year, so you should know it pretty good, but quickly go over it. Autoimmune disorder. It's an acute demyelinating disorder of the PNS. And it's a post-infectious immune reaction. In terms of the infections that cause or more likely to cause GBS. It's your Campylobacter jejuni, herpesviruses, so like EBV, as well as SMV and HIV, more likely to cause GBS. How it presents, it's short onset, so onset of hours to days, and then obviously you have a preceding ED or a diarrheal illness from one of these infections, and which is the most classical presentation, is this ascending flaccid paralysis. Can do a number of investigations, and management is supportive, but if it's severe, you can trial this like high dose IV immunoglobulins or plasmapheresis. So we finished the neurology section now. So great job, everyone. Hopefully you found that helpful. Just do a quick revision with this buzzwords and matching up these buzzwords with the condition. So first of all, infant drawing up legs, flinging out arms. What do we think it is? Your West syndrome or infantile spasms. Same thing. And then next one is hemifacial contortions, inability to speak, abnormal filling in tongue. What do you think this one is? This is your benign Rolandic epilepsy. So remember, you get this focal presentation, the hemifacial contortions, inability to speak, episodic visual distortions or hallucinations, and migraine-like headaches, benign occipital epilepsy. This one, like you're just matching up with visual distortion and hallucination, giving you the occipital epilepsy. So drop attacks is atonic, aka ectonic seizure. Multiple different seizures, neurodevelopmental delay. This is a really bad one. This is a Lennox-Gastaut epilepsy syndrome. Seizure after a fright, either breath holding, cessation of activity, lip smacking, 3-second spike, wave discharge, absent seizure, lip smacking, massive buzzword for absent seizure, bilateral jerking of limbs, clumsy, consciousness maintained, usually while sleeping. Myoclonic seizure, tinnitus, bilateral frontal headache and visual blurring, idiopathic intracranial hypertension. This is the three classic symptoms that you match with this. Throbbing headache, teenage girl, worse when looking at lights, obviously migraine, headache at the end of the day, and band-like, it's your attention headache. So obviously we didn't go through all of these conditions. Not all of them were on the neurology matrix, but I think it's just good to like revise everything in the context of, the conditions that come up. So last revision section. So this is a port wine stain. This is really a big buzzword for something called a Sturge-Weber syndrome. There's so many different syndromes, so I think it's really good just to rely on these MUPPITS tables that have been created by past students and they get you through. So next one, Café spots, neurofibroma, optic-glioma, and Lish nodules. This is neurofibromatosis type 1. Fibromas in the brain, bilateral acoustic neuroma, neurofibromatosis type 2. Char green patches, ash leaf spots, periungual fibroma, and adenoma sebaceous. Tuberous sclerosis. Again, all of these conditions will be they're come under neurology, but they're under a different area of the matrix that will be presented by someone else in the MUPPITS lecture. So hopefully they do that well. But if you're not sure about all these inheritance conditions, definitely just rely on these buzzwords, because that's all that comes up. You don't need to know more in-depth detail. So next one, morning headache, vomiting, papilledema is cerebral astrocytoma. Headache worse in the morning, ataxia gait, and nystagmus, medulloblastoma. Fever, tonic-clonic seizure lasting 5 minutes and they're less than 6. Febrile convulsion, difficulty chewing and swallowing food, bilateral ptosis, myasthenia gravis, worsening ataxia, distal leg wasting, Friedreich ataxia, progressive distal muscular waste, progressive distal muscle wasting, high arched feet, and motor sensory neuropathy is Charcot-Marie Tooth. Next one, unstable walking, multiple ear infections, ataxia telangiectasia, history of trauma abuse, shaken baby, subdural hemorrhage, and hypertonia, fasciculations of tongue muscles, absent tendon reflex is your SMA. These just a couple more. As I said earlier, like I use these tables and like revising with buzzwords a lot with peds because peds Monash is very buzzwords heavy. So definitely encourage you to study like that. This is just one of the couple of tables that I use. So generalized seizure, how we're managing with someone that presents a generalized seizure, first line valproate or lamotrigine. Absent seizures management, first line ethosuximide. Focal seizure management, it's carbamazepine or lamotrigine. This one's looking at side effects and linking, okay, this person had this medication, got these side effects, what's the medication contributing to it? So agranulocytosis, hepatotoxicity, carbamazepine, increased weight, alopecia, and trachogenic, sodium valproate. Can make an absent seizure worse. What do you think that one is? It's carbamazepine. Sedation in children, hirsutism, gingival hyperplasia, skin reaction in the Asian population, phenytoin, and weight gain. It's obviously like such a broad symptom, but we're looking at it in the context of antileptic medications, pregabalin. That's a very like broad symptom, but yeah, good to know. So yeah, that brings us to the conclusion of the musculoskeletal and neurology Muppets revision lecture. I hope you guys found it useful. I think I just wanted to finish on some general revision tips. Definitely try to do as much of the past practice papers as you can. It keeps you accountable. It tells you if you're on track. It also helps a lot because a lot of the questions do get reused, particularly in peds. Next tip I'd give is definitely use the Rupert Hines notes. So, a previous Rupert Hines student made these tutorials and like a thing called the Paediatric Bible. I would definitely read them and use them to revise because they're really high yield notes. And if anyone, has Rupert Hines as their tutor, that's awesome. I'll listen to everything he says. The next thing is, buzzwords. So Muppets, like I said earlier, Muppets has a buzzwords PowerPoint. So definitely use that to revise. Fourthly, revise with your friends, like revise with your mates. It helps so much and it really helped me so much last year. So what I mean by that is like quiz each other, sit papers together, spend those long days at the library revising together because again, it helps keep accountable. If you've got any cracks in your studying, they'll fill them, and vice versa. And it just helps a lot, I think. So definitely recommend that. And finally, try and enjoy the process. I've got the gift for enjoy the ride. You're only in fourth year once, hopefully. So yeah, just enjoy this process. You'll be in fifth year before you know it. And for a lot of these things, you won't be revising it again. So, if you're not pediatric inclined, but if you're not pediatric inclined, you probably won't revise your peds very much again. So I think it's good to just make sure you give it your best shot and enjoy it because you may not be revising peds ever again, which is crazy to think about. Yeah, thank you guys. Feel free to message me if you have any questions, but otherwise, hope you found that useful and good luck.